Well, good afternoon, everyone. My name's Mark Hedrick. I'm the president and CEO of Plus Therapeutics. And we're here in a Plus Therapeutics drug manufacturing facility. We're here with one of our patients, Jim, who has had the rhenium obisbemeda treatment for recurrent glioblastoma back in January of 2023, right, Jim?
Yes.
Yeah. Welcome. It's good for you to take the time. We really appreciate it. And I love doing this, not only connect with the patients that we treat, but just helps me kind of calibrate what we're doing and kind of figure out how we do things better. So I really appreciate it.
No problem.
So what I thought we'd do first is just start off. I'd like to hear a little bit about your background. You're a smart guy with incredible background, and maybe you could just talk a little bit about that for us and let the audience kind of hear from you.
Okay. I have a PhD in physiology. I teach at the medical school here in San Antonio. I've been teaching here for 24 years. And I teach medical students, first-year medical students, I teach them renal physiology, which is one of their favorite classes. They actually hate it. But I've enjoyed teaching them for 24 years now. It's fun to see them mature and actually develop their understanding of renal physiology. So to get to where I am now, I did 4 years of undergraduate work, 4 years of graduate work, and then 4 years of postdoctoral work. And I was a professor now for 24 years, and I am now, I retired, but now I'm an emeritus professor. As I said, I've taught for 24 years here, and I'm teaching medical school at the highest level possible.
And I'm sorry if I didn't mean to interrupt, but your focus area was on cellular physiology and systematic biology, is that right?
Yeah, so I teach cell systems, and a broader focus. I also teach how animals respond to salt and water changes. And so we have a pretty diverse research program in my lab, and normally I have about 8 to 12 postdoctoral fellows in my lab, and I run a training grant that has about 20 fellows that it supports.
As we say, you're a sophisticated medical consumer. You almost know too much, probably sometimes, right?
Yes, it's fun. It's fun to shape the graduate students and the medical students. But I would say I have so many of them in my lab. Sometimes it's hard to figure out how to help them achieve their goals.
Mm-hmm. That's great. Well, I remember those days many moons ago, being in physiology as a first-year medical student. So fast forward through your background. So you got sick in May of 2022.
Yes.
Yeah. Could you tell us a little bit about how you realized something was wrong? I know this really resonates with patients because there's all sorts of different presentations of glioblastoma.
Yes.
And what's your story there?
So I was skiing with my brothers. I have three brothers, and we were skiing at Whistler in British Columbia, and I started getting very bad and painful headaches, and I guess that's a very common thing with glioblastoma. So I came home early, and the headaches got progressively worse, and nothing would help them. Mm-hmm. I would take, lots of aspirin, lots of NyQuil. I thought I had a sinus infection originally. I thought my goggles were pressing on my nose, causing a sinus infection.
Pretty common to come back with a headache from skiing, right? For lots of reasons.
Yeah, every time I go skiing, I get that kind of sinus infection. So I thought nothing of it.
Right.
I came back to Texas, and the sinus infection didn't go away. Mm-hmm. So I saw my primary care physician, and I told her it was a sinus infection, that I get it every time I go skiing. Mm-hmm. And so she started treating it with antibiotics that did nothing. We finally got to the sulfa antibiotics that are known to cause nausea. And so we were going through those, and my headaches were not getting better. And I've been in research long enough and medicine long enough to know that if you have headaches that don't get better with antibiotics, and you start feeling woozy, that means something's really going on with your brain.
Happening, yeah.
Yeah, and so I started getting very concerned about that.
Right.
And so I went to my primary care physician again and said, it's time to get a CAT scan or MRI. We have to see what's going on. So I went to get a CAT scan, and it came back with a mass growing in the middle of my brain, right next to the thalamus. And of course, that petrified me. You know, that's the last thing you want to hear is that you have a mass in your brain.
Oh my gosh. So you were in the ER at that point?
Yes.
You were
Sure.
and so sick from the tumor
Yes.
with nausea, vomiting, and headaches and all that.
And I was stumbling around. I really didn't know what I was doing anymore.
Right.
When I came home that last day, I parked the car right in the middle of my yard.
Yeah.
And just because I didn't know where I was.
Right. Goodness. It's scary.
It is.
So the ER doctor came back and said, hey, you've got a mass there.
Yeah, a mass the size of my fist.
Wow.
And so I had a mass effect, what caused my brain to shift. And that is what made me so loopy. I didn't know what was going on.
So they put you on steroids probably at that
Yes.
point? And did you kind of clear your symptoms up pretty quickly after
The
that?
steroid helped, but they didn't clear it up for sure.
Yeah.
I was still wandering around the hospital not knowing where I was.
Yeah, wow.
And I had to ask my wife, where was I? Where am I?
Right. Right.
And so I had been, after they diagnosed my mass in my brain, I started doing some reading. And there's all kinds of things that could cause a mass of that sort. But the one that struck me as being probably most likely was a glioblastoma. And the reason I thought that is there's not a high percent chance of getting it, but when you do get it, you have very peculiar symptoms to include how I was behaving.
And it goes quickly. It's aggressively growing.
Oh, it's
tumor.
It's one of the worst cancers you can get.
Yeah.
After pancreatic and lung cancer,
Right.
It's the worst one you can get because it has two problems. The first problem is that it grows on a molecular and a macro level. So you have the cell sending out little tendrils into your brain that is invading the brain, and then at a macro level, you have the cells forming a solid tumor that puts a shield around the tumor, so it becomes very difficult to access the tumor with chemo drugs and other types of drugs.
There are so many limitations or constraints around treating GBM. The blood-brain barrier, which you know better than I do, and that infiltrative nature. Surgery, you could take out the tumor you can see, but you can't treat that infiltrative part
Exactly. So
around the tumor. Right?
So they did a resection surgery on me to get as much of the tumor as they could, but my tumor was right next to my thalamus, and so there's no margins on the
Right,
these kind of tumors. You can't get them.
The thalamus is one of the most difficult places to treat surgically, I think, particularly with the GBM. It's tough, very tough anatomy.
Yeah, so you can't get to it, and it's very aggressive and growing.
So did they recommend the usual treatment for primary glioblastoma?
Yes.
Surgery, radiation, chemo?
Yes. So I did the standard of care. I had the resection that removes as much tumor as they can, and then I went on chemo and radiation. I was on that for about 9 months. And so the standard of care did nothing to my tumor. And it should have, because my tumor was it was methylated, and that makes it more sensitive to one of the chemo drugs that's used.
Right.
And that chemo drug did nothing to my tumor. 9 months later, the tumor came back. And that happens to almost every glioblastoma. they almost always come back. And so you think you're on the right track treating it, and then 9 months later you find out you're wasting your time.
Right.
It's not doing anything.
You got the debulking procedure with
Yes.
the surgery, but they didn't remove it all, and because it's infiltrative, there's tumor that you can't see on the MRI, but you know statistically it's there.
Yes.
And so that's the function of the radiation, the chemo, to kind of address that outer part. But sounds like not much effect.
Yeah, I wouldn't put much faith in the regular standard of care. If I had stayed with standard of care, I probably would have been dead within 2 months of that.
Oh, wow.
Yeah, it moves so fast.
Well, let me ask you a question. So when you had radiation, how many weeks did you have radiation? Were you going every day to get radiation?
I was going
Fractionated?
every other day,
Uh-huh.
and I could definitely feel it. I was getting weaker. I used to walk 7 miles a day, and I couldn't walk 4 miles anymore.
Right.
And eventually I couldn't walk 1 mile.
Right.
And so
You get really tired with radiation.
Yes,
here. I haven't had
radiation.
it, but yeah.
yeah, radiation and chemo isn't very fun.
Right.
And obviously it didn't solve the problem for me.
Right. Right.
And so then I had heard, since I was a scientist, I started doing a lot of reading, and I heard about the rhenium ReSPECT trial that Dr. Brenner is in charge of. I heard about it through his brother. His brother and I had gone to school together, and we were talking about my cancer.
And you guys were on the faculty together, basically,
yeah.
at the medical school. And this, remind me of the time frame. When was this? When you met Dr. Brenner?
Okay, so
Was maybe end of 2022,
it was probably
early 2023.
I've known Dr. Brenner my whole career. So I would say on the faculty here, I met him in maybe 2020.
Okay,
Since I had known him,
I see.
we reacquainted with each other.
And then you saw him professionally for your cancer, kind of about what time frame?
Yeah, so professionally for my cancer, I saw him in 2022.
2022.
Yeah, that's when the cancer really first appeared, May of 2022.
And then you really didn't have a good response to chemo and radiation. It had come back by MRI, and you looked at the ReSPECT-GBM trial, and then I think you decided to enroll in the trial, and then you had the rhenium procedure in January of 2023. Is that right?
Yeah, that sounds right.
Sounds right. So tell me a little bit about your thinking process for going into that trial versus doing, there are lots of GBM trials. Why did you pick this trial versus something else?
So after reading about the trial, it looked like the one that had the most success and the one that would give you the most time. So with GBM, what you really are fighting for is time. Ultimately, there'll be a cure for this. It's not going to happen tomorrow, but there will be one. And so what you do is you fight for time. And with GBM, time is months. It's not decades.
Right.
Not right now.
Right.
We hope to get the decades, and that will give you more time for a cure. And I think the rhenium trial will give you more time, and that's why I went into the ReSPECT trial.
Makes sense. You look at the data, it looked promising.
Yeah.
You knew the principal investigator, which kind of gave you a comfort level, I'm sure. He was right there. You weren't flying to, Seattle or something. And so you decided to do the procedure. Tell me about the procedure, the pre-op. You went into the hospital, had a biopsy. Then they put the catheters in, and you were up on the floor with the catheters, and then you had the treatment delivered, and then the catheters come out and you go home. That's the procedure, right?
Yep. The procedure is one of the most simple surgery I've seen and been involved with, especially neurosurgery. So what they do is they map your brain with an MRI, and then they stick catheters down into your brain, and they stick them right on top of where the tumor is. And that's an important point with GBM. GBM, the M stands for multiform, and that's why it doesn't respond to chemo in radiation very well because it's constantly changing what it looks like. And so with the catheters, they don't have to worry about targeting the cancer cells themselves. All they use is a location to target it. And that's why I think it's so effective.
It's tumor level targeting.
Yes,
Tumor and infiltrative zone.
Yes.
Not just the tumor you can see, the tumor you know
Yes.
is there lurking that's going to be responsible for the recurrence.
Yeah, and they use geography to kill the tumor,
Right.
instead of what it looks like.
Right.
And so it's a very simple surgery. They put the catheter down right to where the tumor is, and then they stick rhenium in down the catheter. And rhenium is a radioisotope, and it kills the tumor that it really kind of surrounds. And the tumor can't stand that radiation level, so it dies. And once it dies, you have more time. Go ahead.
So that, no, I was just going to, if we could, just kind of back up a sec. So you were admitted to the hospital. They did the planning. The Dr. Brenner and the team, Dr. Floyd did the planning. You're admitted to the hospital. You go to the operating room. They do a confirmatory biopsy, put the catheters in, and then you recover and go to your room, right?
Yes.
How was that procedure? Did you tolerate that okay? Did you?
Yeah.
How was that versus the neurosurgical procedure that you had?
It was. I'm laughing because it was kind of funny.
Yeah.
So I had the surgery. They put the rhenium down the catheters right to the tumor, and then they take the catheters out. The way they took my catheters out, Dr. Floyd walked into the room and said, "It's time to take them out." He grabbed them and pulled them out. And I was praying to God nothing was sticking.
That was probably easier than the staples you had
Yeah.
removed on the prior surgery, I
Yeah.
bet, right?
Yeah, it was. I mean, it's the simplest surgery I've ever seen,
Yeah.
at least to finish up.
Yeah.
And there's very little danger in that surgery.
Yeah.
The most dangerous part is feeding the catheter down to the tumor.
Right.
And these guys have the MRI, and so they know exactly where they can go with the catheter.
Yeah, it's really remarkable. There are actually products on the market now. We use it's a software planning system that's made by Brain Lab. They also make the catheter, or the tiny catheter, but it allows you to plan the catheter placement so you avoid all the critical structures, the veins, the arteries, the speech areas, the hearing areas. So the pathway the catheter goes is as safe as possible. So I think that's one reason we really haven't had any catheter-related complications because the planning's so sophisticated.
Yes.
And then, the catheter's taken out rather abruptly. And then you went home the next day, I bet, right?
Yeah.
Or maybe that day, I don't know.
I went home the next day.
Uh-huh.
I had been walking about 7 miles a day with my wife. I came home the next day, and we walked 7 miles again.
No kidding. So you left the hospital, you walked 7 miles
Yeah.
right after that. Wow.
Yeah, I mean, it was a nice day, so we walked
Yeah.
a couple times. And I didn't have any problems controlling muscle or...
Headaches or any?
I had a few headaches.
Yeah.
But anytime they stick something in your head,
Yeah.
you're going to have headaches.
Yeah.
And so the functionality was really good. The
Yeah.
headaches didn't bother me because I could actually walk.
Right.
I've had subsequent brain surgery, and I've lost function on my left side.
Really?
Yeah. And
Yeah.
I have to work a lot harder to get that to allow me to move. The rhenium in the ReSPECT trial gave me no problem at that time.
Right.
There is one side effect worth worrying about, and that's radiation necrosis. And they have several ways to deal with that. You can do it with steroids. There's something called Avastin. You can deal with it. It goes away pretty quickly.
Yeah.
And so you're trading your life for a couple of weeks of headaches. That's
Right.
really what it comes down to.
Right. Yeah, the radiation necrosis it's an interesting thing because you want radiation necrosis on the tumor.
Yeah.
That means that if you see necrosis means death. You're a physiologist, right? It's death of the tissue. So you want death of the tumor, just not death of the normal brain.
Yeah.
That's the idea. And sometimes the bigger the tumors are, there's that tumor dies, it creates some swelling and other things, but you probably had steroids after that, and it controlled that. Sounds like you're right back walking afterwards. And so we talked about this earlier, so I'll kind of prompt you with this, but you were doing fine, but you'd done your reading, you know about glioblastoma, and you're thinking, okay, it's probably going to come back. I got to be thinking, what's next, right?
For sure.
How are you sort of processing that? And
so I hadn't realized that the rhenium trial had reopened for people who have another recurrence.
Right.
And so if my recurrence, if I ever have a recurrence, I'll definitely come back to the rhenium trial because there's very few side effects, and it saved my life. If I hadn't done the trial, I would have been dead in 2 months. And so, like I said, we're fighting for time with this disease.
But at that time, that trial was just approved fairly recently.
Yes.
That we can do a second procedure on patients. But at the time, you were looking around at other opportunities to.
Yes. I looked at the CAR-T trial, and I'm still looking at it.
Yeah.
I haven't ruled it out, but I think the rhenium trial is simpler and safer than the CAR-T trial. I'm not ruling out the CAR-T. I got to do some more reading.
Right.
But I'm blanking a little bit. But the trial with rhenium was so simple that would be my first choice.
And on the reason you're in a wheelchair, you mentioned earlier, is that the CAR-T trial, they had to take you off some of your other medications that were really controlling swelling and edema, and that made it then more difficult to walk, which is why.
Yeah, I wasn't qualified for the CAR-T because you have to be able to do average day living kinds of things, which you have to get up, take a shower, make yourself breakfast. We can all do that, but once you have GBM, it becomes more difficult. And so I'm not clear to do the CAR-T, but I hope I'd be clear to do the rhenium trial, the second phase ReSPECT trial. It's a simpler trial.
Right. And where you are right now is that you're getting your MRIs every 2 months and no evidence that it's come back.
No evidence, and in fact, the opposite. I recently had a needle biopsy where the tumor is, and they found mostly necrosis, necrotic cells.
Yeah.
And that means those cells are dying.
Right.
And a lot of them are
tumor cells, which is what you want, right?
Yeah. I want those cells to be dying.
So it's not uncommon, just kind of speaking, but the history of the trial is that you get something called pseudo-progression, where you look at the MRI and actually a few months after the procedure, you're not sure. You look at the MRI, maybe the tumor's actually gotten a little bit bigger, but then you continue to follow it, and then it actually goes back down. That's called pseudoprogression. And speaking not as a neurosurgeon, but as a doctor, but basically the way I interpret that is if the tumor's responding, you're getting necrosis, the tumor's dying. Sometimes it makes the tumor look a little bit bigger, but actually it's a positive thing.
Yes.
And then sometimes when you're not sure, the simple answer is do a biopsy and double check. And you had that how long ago?
Probably about 3 or 4 months ago.
3 or 4 months ago, but it came back. You were happy, I guess.
I was very happy.
It was negative. So
there was no sign of disease progression whatsoever.
And so you're 18 months out.
Yes.
Just had a biopsy that was negative. And so you're still kind of you're waiting for what's next. But as of today, you could say, "Hey, I just had a biopsy. I'm tumor free." And
that's what Dr. Brenner actually brought up. There's a tumor board here that looks at all the tumors, and they try to analyze whether the tumor is growing or not.
Right.
So Dr. Brenner, when they looked at my biopsy, they were, of course, discussing, is that a tumor or is that not a tumor?
Right.
And Dr. Brenner made the observation, we don't know if it's a tumor or not, but there's no sign of pathology.
Right.
And that's the important thing.
Right, that's fantastic.
Yeah.
That's awesome.
Yeah.
That's great to hear. So that was just recently. So you're kind of following for the follow-up regimes with multiple MRIs, and now this trials that being able to have a second treatment is now an opportunity. So we watch it, cross our fingers, hope it's cured, but we're realistic, and
Yeah.
you don't know what's around the corner. So it sounds like you're considering a couple of options. So we're here for you if you need us, and I really appreciate you doing this. And I did this with another one of our patients, Phyllis, in the past, and I heard from prospective patients, some of our investors, other doctors, just how meaningful it was to hear, a patient's journey. And I know it's not easy, kind of sitting here in a cold room, talking to me, but patients really welcome hearing in venues like this what the journey is like, and somebody with your background, your sophistication, your education can demystify that for patients. So I think this will be really impactful for a number of patients. So I really appreciate you doing this.
I hope so.
Yeah.
I can definitively state that this trial saved my life.
Yeah.
Without this trial, I would probably have been dead 2 months after I finished standard of care.
I can't tell you how good that makes me feel. So we're gonna keep plugging away.
Good.
So I really appreciate it. It's been great meeting you, Jim. Yeah.
Nice talking.
Okay, you too. All right.